Hello and welcome everybody to ICMDA webinars. I'm Dr. Peter Saunders, the Chief Executive of the International Christian Medical and Dental Association, which brings together about 60,000 Christian doctors and dentists from over 100 affiliated national movements worldwide. And today on ICMDA webinars, we have Dr. Beatrice Ambauen-Berger, who's going to speak to us on the challenges of female genital fistula. Though many doctors in the West may have never treated this condition, there is still an estimated 500,000 women worldwide suffering from this preventable and treatable disease, mostly in African and Asian countries. Sufferers are living with full incontinence of urine or stool and are often treated as outcasts in their local communities. Where access to medical care has improved, the numbers of obstetric fistula have decreased. But sadly, there is a concerning increase of fistula caused by low-quality pelvic surgeries. This webinar will give an overview of the causes and challenges of female genital fistula today, with focus on the example of Bangladesh. And Dr. Beer is based in Bangladesh. She's a Swiss obstetrician and gynecologist. She works at the Lam Hospital in rural Bangladesh and has been there since 2010. And besides practicing and training local doctors in obstetrics and gynecology, she led and expanded the Lam Fistula Project, including performing and training nationals in fistula surgeries, consultancy for community projects, local and national advocacy work, as well as fistula-related research. She's a member of ISOFS. Yes, that's a five-letter acronym like ICMDA, which stands for the International Society of Obstetric Fistula Surgeons. She's been a member since 2012. She's also a member of the ISFOS Executive Committee from 2022 to 24. So, Dr. Beer, it's such a pleasure to have you here today. Such an important subject, and we really look forward to hearing what you have to say and engaging with you in Q&A afterwards. So, over to you, sister. Thank you.
Yeah, good afternoon, good evening, good morning, not sure where all people are coming from. Thank you so much for this introduction, and it's definitely a privilege to be speaking here. Feels a bit strange because I have listened in so many times to be now on the other end, but I think it's indeed a very important topic. And my goal is that at the end of this presentation, you will have a basic understanding of what female genital fistula means and what the challenges are. And I do hope that many of you will be encouraged and challenged to actually help contribute in whatever way you can, wherever you are, that this disease will, the suffering caused by fistula will be overcome. I'll jump in with 3 stories. This will give you a good view, and I'll start with Kulsum. She's actually one of the first fistula patients that I encountered when I started working at Lam, and I still remember how she had come into our OPD, sad, bent, miserable lady, very despaired. For me, it's like the personification of despair and suffering. And then I heard her story, how she got married very young, just as she got her menses. She got pregnant right away. She labored for days and delivered a dead baby. And then after delivery, she noticed that she can't control anymore her stool and her urine. So when this happened, her husband sent her back to her parents. And that's where she had stayed for the last, how many years? 20 years. Thinking she's cursed by God, she's the only one having this problem, not able to go out to meet other people, in shame and suffering. And somehow she heard from another patient that at Lam there is treatment, so she came. And as you can see, she did get cured. She got operated by Professor Saeba. This is our great specialist in Bangladesh. Bangladeshi, amazing lady. I think she wanted to join, I'm not sure. She's here as well, and could get a new life. Meeting patients like her gave me a very different perspective when I then was reading how Jesus treated outcasts, how he touched women, the woman with the bleeding, or leprosy patients also. It suddenly gave such a different perspective. Yeah, this is the story of the classical story of an ischemic obstetric fistula. I'll explain more later on. Let's jump or go over to Fatima. She didn't go into any long labor. This happened not very long ago. Cesarean sections available. She got a cesarean section for her first child because she didn't go into labor, and it seemed very convenient. And of course, she would take another cesarean section for the next child. But it happened so that her labor pain started in the night, and the family was looking for a place to get the cesarean section, but they couldn't find it. And then in the morning, they found a dead baby and a ruptured uterus at the scar. So she needed hysterectomy due to bleeding. And then after a couple of days, she noticed she was leaking urine. This is not an ischemic fistula, but still for us, we call it an obstetric fistula because it was in this obstetric disaster. She also could get operated. And this is a third type of story, Momota. She labored at home and came late to some clinic nearby in obstructed labor. And as they did her cesarean section, probably there was a very junior doctor. He tied both ureters accidentally, and she came to us in renal failure, but we could save her kidneys and her life. This story is not that common in Bangladesh because there is health facilities are available, but I know that in African countries, this is quite common that very little is available. And those often junior doctors who have to try to save women, they save their lives, but then complications are common. Yeah, so I'm talking about Africa, about Bangladesh, Asia. Is it a problem just of these countries or of just low-income countries? What I find very interesting, and you might not have heard, is that the first fistula hospital wasn't the one in Ethiopia that maybe many of you know. It was actually in New York in the middle of the 19th century. So from this, we very well know that it has also been in Western countries. And I found it very interesting, obviously, that one of the first books about fistula surgeries was written by Dr. Faber or something like this in Basel in Switzerland. Yeah, but it's a fact that I have been, grown up in Switzerland. I have been trained in Switzerland, and even in my all of my medical school, in no book it was written about fistula, and I didn't even learn that fistulas can be a complications of pelvic surgery. So we have forgotten, but it was there before, and it is, as already Peter mentioned, it's preventable and treatable. So that's the reason why it's not really happening anymore. And sometimes people say, like, we can never end fistula because even in the West, fistulas happen. I don't fully agree. I mean, there can be cases after radiotherapy or oncological surgeries. And for sure, injuries to the bladder, to the ureter are happening also in the West, but never would we leave women suffering for weeks, months, years, decades with the fistula, but we will try to treat these problems. Yeah, so one of the big questions, obviously, is how many women are suffering from fistula today? You might have heard that traditional estimate of 2 million. There has been a more recent estimate by the Johns Hopkins University, where they were trying to calculate from the maternal mortality rate, birth attendance, and fertility rates. And they are talking about 500,000. Basically, we don't really know. It's very hard to find. In Bangladesh, there was an estimate in 2016, 19,000. It doesn't seem to be so much. Seems to be possible to overcome, but I'll share more later about that also. I just picked one African country, Nigeria, lots of patients, even recently estimated. And of course, the next question is how many operations are done? That's the main treatment of fistula. I found on the internet 20,000 maybe per year. Bangladesh, my guess is 600. Nigeria, it says 3,000. So it doesn't need a lot of mass skill to see the discrepancy. So many cases and so little still done. So that's, I find very depressing when I see this. The question is, how can we ever end this suffering? There have been many efforts in the last 30 years, 20 years, just going through the most important. This campaign to end fistula was launched by UNFPA 2003. Many surgeries done, many projects. USAID joined in 2007. Then ISOS came together, all fistula surgeons or gynecologists, urologists, surgeons who wanted to work towards ending this problem. Fistula Foundation also has a program to end fistula. And FIGO, the International Gynae Society, they launched a big training in 2012. And there is many more organizations who are contributing. And what is definitely important and has probably contributed to that is that ending fistula is part of has been of the Millennium Development Goals, also of the Sustainable Development Goals. And in 2020, there was even a UN resolution to end fistula by 2030. Now we are 25. So when you have seen the numbers above, we still lots of work to do, probably. Now I'd like to step back to the basics for those who don't really understand yet what I'm talking about. So what is actually a vesicovaginal fistula? This is one type of female genital fistula. Here, the picture for the classical ischemic obstetric fistula. So when the baby gets stuck in the birth canal, the bladder gets compressed between the skull and the pubic bone. And through this pressure, there is an ischemia and then a necrosis in the bladder. And there remains, afterwards, there can be a hole where urine will be leaking out through the vagina. If the pressure is to the back, then it will be a rectovaginal fistula. And it can look so different, depending where the pressure was, how long the pressure was. It can just be a tiny hole somewhere in between bladder and vagina, or it can look more like this, where like all of the anterior vaginal wall is gone. And only a dimple left as urethra. Bladder is very small left. I'm showing you one picture now. Like imagine if you are as a gynecologist, look into the vagina. That's the picture on the left. You directly look onto the bladder. Sometimes the ureters are spurting in your face. That's a big, huge fistula. And this one is just, we put in a catheter into the bladder in the urethra and it's coming out in the vagina. So that's the connection. And if it's not big enough to go a catheter through, then sometimes we just put blue and the blue color will come out. So a connection between the vagina and the bladder, that's a vesicovaginal fistula. And what's important to notice is that it's not just a hole. If it's a small fistula, then it's basically a hole. But for the severe cases, it's really more a disease. Besides the continuous losing of urine and stool, and continuous means continuous. Wherever you are, you make a puddle. Wherever you are, it gets wet, it smells. But beside that, there is often also vaginal scarring, stenosis, so that intercourse is not possible anymore. The kidneys can be involved, and often they don't get pregnant again. Besides the vesicovaginal fistula, which is VVF, we call the most common, there are many other different types, especially nowadays after surgeries. I'm not going to go into details. And I would like to mention one more also neglected issue is old fourth-degree perineal tear. Even some people don't consider it a fistula, but actually it is also a connection between two compartments, and it is making the same suffering and the same symptoms as an rectovaginal fistula. And we have done quality of life follow-up and seen that it's the same improvement through actually a relatively easy operation. They can get restored her perineal body and the bowel function. I've already mentioned quite some challenges, but here I tried to put it together. Obviously, if we ever want to end this, the most important is to prevent. Then it's also a challenge to find patients and to motivate them to come for treatment. The treatment itself and rehabilitation, and then what to do with those who can't get cured. Let's start with prevention. I think that's the most important part because the ongoing still every day new fistulas are happening. So we have to do something to stop this. And what makes it most challenging is that actually fistula is not just a disease, it's also a symptom of a failing healthcare system and of discrimination against women. When we think about how to prevent obstetric fistula, it's the same as preventing maternal death. Many of you, I guess, know the 3 delays model. Seeking care, reaching care, receiving care. At the time, the delay that happens because a family doesn't go to a hospital when there is a problem. And that's obviously very much influenced by money, poverty, education, what value is given to a woman to even try to save her life or the child she's bearing. Child marriage being one important factor in this. Then the delay in reaching the place of care. In Bangladesh, even if it's just with a vanguard like on the picture, it's not too bad actually, because it's very densely populated and there are healthcare facilities in many places. But when you go to Ethiopia or Sudan, in these countries, it's vast. It takes days often to even reach a road. So it's poverty on one hand to have the money to go, but also infrastructure and geographical areas. And then the third point is receiving care. So finally, somebody reaches a clinic or a hospital, but will they find somebody who is even there? Will they find a doctor? Will there be materials? Will there be electricity? Will there be medication? Will it be given free as it should or affordable, or is it all corrupt? So that is the third. So it's the whole prevention is much more than the medical part. It's just so complex. And then we are thinking about other causes. This is the last 3 years at LAM, like with what causes we have seen fistula. You can see that obstetric is about 1/3 of the cases, and half is surgical. I'll talk about this more later. Then we also see malignant fistula. Mostly this is cervical carcinoma. Also a disease that is increasing in many low-income countries, and it's not only significantly contributing to mortality in young women, but also fistulas can happen. Congenital fistulas we also see regularly and often in actually adolescent girls because they don't seek help when girls are little. And then traumatic fistula is very little in Bangladesh. But if you go to countries that have conflicts and war, it may be a very significant proportion that is caused by mostly sexual violence. So surgical iatrogenic fistula is definitely significant in Bangladesh, as you have seen, and in other countries of South Asia, but it's also increasing in many African countries. And there it's mostly after cesarean section, whereas in Asian countries, maybe more hysterectomies. It's not the newest data, but I think it just has gone up higher from what I hear in various presentations from people also from Africa. So this story has become like a weekly story. And weekly, we operate this kind of women. They have a bleeding problem, they go for ultrasound, then they are told you need a hysterectomy, they are referred to some clinic who removes their uterus. Often also the ultrasound was because of other problems, just some pain, and they are told they have a tumor. And then after the hysterectomy, they leak urine. Sometimes they are referred by the doctors, and sometimes they are just spending lots of money to try to get cured, and finally maybe another fistula patient finds them. I'd like to share some more numbers from us. This is from since 2011. You can also see roughly, this is nearly 1,500 patients. So we are not like some other hospitals that are operating every year, thousands of cases. But you can see the trend, how in 2011 it was very rare, the surgical fistula, and now it has become more than 50% in the last 5 years. This was all the fistula patients that we have diagnosed. Many have suffered for a long time. And here we looked at only those who got their fistula in the previous year. So this is reflecting what type of fistula are happening now. And it's more than 80% that are surgical. Here you can see after what type of surgery it happens. As I said, hysterectomies, gynecological hysterectomies is the majority. And here you can see where those operations take place. So the vast majority in private clinics, where the focus is on business, and in small clinics that offer maybe cheaper operations by some junior surgeons. We found analyzing these patients also that they are also poor. Like they have some money maybe to pay for the surgery, but they are also poor and not educated. So how can we prevent surgical fistulas? This we keep thinking about in the last couple of years. 2 main points: try to prevent unnecessary surgeries. Lot of work to do in raising awareness, as it's not only the doctors who like to do cesarean sections and hysterectomies, it's often also the patients who think that's the easy solution. Safe surgeries are crucial. We need to invest more in postgraduate training, that those who do surgery really know what they're doing. We have started doing safe surgery workshops among doctor advocacy, but definitely so difficult how to address this. And I think from what I hear, it's everywhere where the private sector and healthcare system is growing, that is becoming a challenge. Let's go to the second point. That's maybe a little surprising at first. You could think with such a horrible disease, nobody wants to live longer than needed, but they don't have this understanding. So it's not easy to find them because they hide, because they are ashamed. And also when we find patients, they don't always want to come because they are afraid of what will happen. So one thing we have been doing in the last years, campaigns in just certain areas, like go around for 1 month training primary healthcare workers and miking and trying to find the patients. And then at the end of the month, we have a diagnostic camp where the doctors are examining and diagnosing the patients. And the area we cover maybe 200,000 inhabitants, and from there we find maybe 5 to 15 patients. So it's not big numbers, but we know that everyone we can bring a new life. It's worth it to invest. And to the right, you're seeing Hasina. She's one who has brought most patients. Also, she herself had a fistula. So we have found that this is very powerful when they go and explain and convince others. Like they are like the best missionaries to bring the good news. This is at a jubilee when we had a picture all together. Now we have, in the meanwhile, 210 LAM community fistula advocates. This CFA brought Tohomina, an old lady. She must have suffered for 50 years. And it was my first tiny fistula I repaired on my own. And I just couldn't believe how her life could change, even at this age. Next challenge, treatment and rehabilitation. It's definitely a big surgical challenge. Whoever likes surgery and likes challenge, welcome to fistula surgeries, because you're working with bad tissue, with tissue loss, difficult to see. And this is maybe the average success rates. If it's a difficult fistula, it will be less. If it's a very tiny one, it will be more. So it needs special skills, also special nursing. It's not just any gynecologist or surgeon who can just do it after watching twice. And the other thing is we need funding. Hardly any of these patients have the money. Some have the money to get the operation to get the fistula, but then they don't have the money for the repair because they sold their last cow for this surgery. Yeah, so projects are needed also for rehabilitation programs to help them come out of their poverty. Yeah, it's only few. Also, what I see in Bangladesh, few surgeons who are really committed to handle these challenges. But this is what is motivating us when we see how new life can be started and how thankful they are and how happy they are. But behind the number of success rate, you know that there are also some who won't be cured, and that's very challenging to handle. So that's my fourth challenge, what to do with those women whose fistula cannot be operated, or maybe they got tried several times and it didn't work. Or they have medical problems. They waited so long, they now have heart disease and are too old. Or some who actually just don't agree because they are afraid or because their family doesn't allow, it's too far away. So at first we need to find them and diagnose that actually they can't get operated, or maybe they could get a diversion like ileum convi. And they should get included in social welfare, like disability programs. We are trying to work for this in Bangladesh. They need support, at least some, like here, she got a cow, to have something that makes a difference in her life. Now, I would like to give you a chance, just 3 minutes, to listen to these ladies.
স্বামীও তো ধীরে ধীরে করে, আশপাশেও ধীরে ধীরে করে যে এখানে ঘেন্না, আমার সমাজে আসবেন না, আমার আত্মীয়র বাড়িতে যাবেন না, কি দূরে থাকা ভালো, এরকম করি আমার মুখের পর কইছিল। এখন আমি কান্নাকাটি করছি আর খুব দুঃখ পাচ্ছি।
10 বছর ছিলি, অনেক চিকিৎসা করছি, টাকা পয়সা নেই, আমরা গরিব লোক। আমার স্বামীও চিকিৎসা করে না, আমার বাবা নাই, আমার স্বামী আমাকে দেখতে পারে না, আমার শ্বশুর শাশুড়ি কাউ দেখতে পারে না, আমি ঘর থেকে বেড়াইতে পারি না, কোনো মহিলার সাথে কোনো অনুষ্ঠানে আমি যাইতে পারি নাই। আমার অনেক কাহিনী, আমার এই জীবন সে আল্লাহ পাক ভিক্ষে দিছে, ল্যাম হসপিটাল আসি।
আমাদের কাছে কেউ আসতো না, হয়তো পাড়া প্রতিবেশী বলতো যে তোমরা এখানে কেন আসি দাঁড়াইছো, তোমরা বাড়িতে যাও। তখন আমার মনে হয় আমার বেঁচে থাকার থেকে না থাকাই ভালো। এমনকি আমার মা যে আমার গর্ভের মা, তাও বলছিল যে তুমি এত অসুস্থ, তোমার এই জীবন নিয়ে আমি কি করব। আমার খুব কষ্ট হইতো। আমার মতো দুঃখ অসহায় কেউ ছিল না। আমার স্বামী কাজ করতে চায় না, আমার খুব কষ্ট লাগে। তখন যখন একটা ধিক্কার দেয়, তখন মনে হয় আমি বাড়ি থেকে বাইরে হয়ে যাই, আত্মহত্যা করি। আবার নিজের বিবেকে বাঁধি যে আমার 2টা সন্তান আছে, আমি যদি মারা যাই তাহলে আমার বাচ্চা 2টার কী হবে। এখন এই জীবন নিয়ে আমি সুস্থ। ল্যাম্পের কাছে যখন আসি, এরা সহযোগিতা করে, আনন্দ পাই, খুব ভালো লাগে তাদের সাথে থাকতে আমার।
আমি প্রায় 10 বছর থেকে ফিস্টুলা রোগে ভুগছিলাম। তারপরে আমি অপারেশনে ভালো হয়েছি ল্যাম্প থেকে। অপারেশন হওয়ার পর থেকে আমি সুস্থ হয়ে 6 দিনের ট্রেনিং পেয়েছিলাম। ট্রেনিং পাওয়ার পর আমি এখন গ্রামে গঞ্জে সবাইকে, মা বোনকে বুঝিয়ে বলি যে আমি যে ফিস্টুলা রোগে আক্রান্ত হয়েছি, ভোগ করছি, যে আপনারা যাতে এই ভুল না করেন। পেটে বাচ্চা আসলে নিয়মিত চেক আপ, টিকা, নিয়মিত খাওয়া, পরিশ্রম করিয়েন, বিশ্রাম করিয়েন, এরকম বলি যে আমি যা ভোগ করছি আপনারা তাদের না হয় এরকম সমস্যা।
মানুষ আমাকে দেখে ঘেন্না করে, আমার অথচ গর্ভধারী মা, উনিও আমার কাছে নিতে চায় নাই। আমার মা বলে তুমি আমার মেয়ে হতে কি, আমার বিছানা থেকে তুমি সরে এসো, তোমার গন্ধ নাগে। তখন আমি চিন্তা করি মানুষ আমার কেমন করে গন্ধ সহ্য করে। তখন আমি বাইরে ঘোরাফেরা করি, আর আলাদা বিছানায় আমি অনেক দিন পর্যন্ত থাকি। থাকার পরে আমি ভালো হয়ে গেছি এই ল্যাম হাসপাতাল থেকে। যাওয়ার পরে আমি অনেক খুশি।
আমি দীর্ঘ মনে করেন যে বলে 21 বছর কষ্ট পাইছি। এখানে আসেনে ভর্তি হয়ে হ্যাঁ আমি ফিস্টুলা রোগ ভালো হয়ে গেছি।
So I will conclude with a kind of summary what I feel, what is needed. A lot more awareness raising about this disease and what can be done. Our maternal and general healthcare systems need to be improved. We need to train doctors in safe surgery. And we need more projects to find the fistula patients and more fistula surgeons and centers to offer treatment. Because we want to offer a life in dignity to every fistula patient. Who will join? Thank you very much. I have, in the last slide, I've added some resources of organizations that are working with fistula and some books and movies. So once this is online, people can have a look. Thank you so much.
Wow, thank you so much, Dr. Beer. And at one level, just incredibly harrowing just to hear those stories and testimonies, and yet at the other, just amazing to see the testimonies of people who've been healed and have been restored, not only physically, but also to their communities as well, because I think it's the social isolation, isn't it? When I worked in Kenya with the Africa Inland Mission, we didn't see a lot of this. I think I only saw one case that I had to repair, but I remember just the transformation in the woman and the look on her face afterwards, just this incredible joy at being restored. And she also came to know the Lord while she was at the hospital. So it was a kind of double blessing. But thank you so much for all the work you're doing and have done, and the incredible witness of Lamb Hospital and the way you've really blazed a trail with this whole thing as well. So we've got a time now for question and answer. And if I guess first question, Dr. Beer, you've talked about the difficulties of the delay in getting to the doctor, the recognition, the lack of skills, and so on. I mean, would you say there's one main or dominant problem that a fix would make a huge difference? Is it availability of surgeons? Is it better education, better awareness? What? Or is it really very multifactorial?
Yeah, I think it is very multifactorial, and it may be depending on countries also. In some places that one thing is more a problem than another. Like in Bangladesh, we have quite a dense healthcare system. Like there is so many options where they can go, but quantity has increased a lot over the last year. So obstetric fistulas, in the sense of obstructed labor, has become very less. Even in our labor room, like very, very rarely we see a patient coming with obstructed labor. But the quality of care is really the lacking.
And
so
is that because... Carry on.
Yeah, whereas in some places, in Afghanistan or Africa, it's just nothing is there. No, there is nothing available. So there, yeah, it will be different depending on what setting.
So that was quite new to me, the fact that surgically induced fistula has increased hugely, and yet it seems also is the incidence of obstetric fistula going down in Bangladesh? And if so, what's that due to? Is it better obstetric care, or is it just that it stayed the same and surgical fistulas just swamped it?
Oh, it's technically, I mean, it's just more available. If they don't try, we still have a significant home delivery rate here, like 30-40% maybe.
Yeah.
But then if the baby is not born, then they'll go to a place where they often get the cesarean section within reasonable time. If it's necessary or not, that's the other point. So there's more risk now that you get a fistula because of the cesarean section than because of trying.
Yeah. So, so thinking about the iatrogenic surgical induced fistulae, what is or can be done at national level to improve training, particularly of surgeons, to to ensure that people have the proper indications for hysterectomy, to reduce the number of cases? It struck me from your slides that most of these seem to come from private clinics rather than government hospitals or mission hospitals. Talk us through a little bit about the regulation and training and what happens and what could be done.
So you're asking specific about Bangladesh?
Yes. Yeah.
Yeah, it's, you have, again, maybe have to see it in a bigger picture. So it's, people like to study medicine because you can make money.
Yeah.
And you will be the one to take care of your family, that you can connect with the right people if you have a problem. Medical schools are a very good business. You can charge lots of money because people want to go to medical school. So it's already starts there, that with enough money you can get through private medical colleges and not even become a really well-trained doctor. Then there is so many doctors who are trained who can't actually get into postgraduate training. So, but as they have spent so much money, they have to make now money to make up for their costs. So you just are very freestyle in doing what you can, or if nobody really teaches, you just do. It's also a lot of use of drugs that is not really necessary. Pharmaceuticals determine a lot. And then surgeries is just more obvious risks.
Yeah.
So there is postgraduate training programs, there are exams, there are definitely doctors who are well trained and working very ethically, but it's also the problem overall of corruption. How can things be controlled? Where is accountability? Private clinics, do they function with a license or even without a license because they paid off the controller? They are connected to the people who are politically influential. Yeah, it's all very interconnected. One thing that we found encouraging, I mean, we feel still very helpless, like what can even be done, but it was even very taboo to talk about this. So UNFPA has organized lots of meetings with government people trying to sensitize, but always talking about obstetric fistula. And then there was this one meeting, I don't think at all this was planned. They called 10 patients randomly who got operated by us and just let them speak. And then it turned out that 8 of the 10 had a surgical fistula. So everyone was saying, I had this operation, then I got the fistula. I had this. So it was just such a loud voice that it couldn't be denied. And in last years, it has become more acceptable to even mention as an issue. But of course, it's very difficult. No, it's very. You don't want to blame your colleagues if as the district doctor you are closing down the private clinics. You may just be removed from your place. Like it's very difficult, this accountability.
Yeah. Can you talked a little bit about advocacy? Chris Prenger here is asking, can you tell us a little bit about advocacy at government level? What's going on? How much awareness is there in government, and how much advocacy is taking place, and also including regulation of what's happening?
Yeah, I think they know, like many know, like those who are at the base, like the district doctors are in charge, like level in the administration. I'm not sure. Like that's what we try also to make meetings to inform them. The Obstetrics and Gynecological Society obviously knows. They've written a statement maybe 10 years back, but It's always the question, what happens with this? I think it's a power situation also, like who is telling who what to do. And yeah.
Amy Robinson is saying, thanks very much for your talk. Very insightful. I'm an O&G trainee in the UK, but still in my training, interested in fistula work in the future. And a few questions. Would you recommend subspecialty training in urogynecology in the UK, or should she get the training abroad? What path did your own training take? Is there anything that trainees can do to become useful before becoming consultants?
Wow. Yeah, it is part of the urogynecology. I've done the regular obs and gynae training, and here we're doing lots of vaginal surgeries. I think that's like prolapse surgeries. That's when you have a good level of skill in that. That's when you can start trying to operate fistula. I mean, I think it has changed a bit, that like there's lots of, I hope there are also African colleagues here, like so many Africans and Bangladeshis, Indians, some Pakistani, also Nepali, who are doing the fistula in their countries. I think as a Westerner to get to a level that is significant, comparable, it's very difficult. Even if you are, like we have sometimes urogynae professors, they want to come and help, but we feel, no, it's really still something different. You need the experience with that. Like there were these very big surgeons, most of them have lived for a long time in Nigeria, Case Waldeck, or of course, in the Hamlin Hospital. Then of course they are there. They know all the skills. Like I also never had the ambition to become a really high-level fistula surgeon. I'm just doing more the basics, and now we have more like specialized in doing surgical fistula, which it's quite different than obstetric fistula. But we have some nationals who are very good, and they are doing that. So as a British gynecologist, to be involved, you would have to move to one of these countries and learn then yourselves. But the basis, urogynae is definitely a good basis, or just a good vaginal surgeon.
Yeah. I mean, it sounds like really most of your training and experience was on site at LAM, and even though you had the background, that's really where you learned it.
Yes, totally. Well,
yeah. The Hamlin Hospital, of course, is very in Ethiopia, isn't it? It's very famous, and there's a story there of a lady who'd had a fistula repaired, and then was so grateful she wanted to help, so she started cleaning the floors and then assisting with operations, and then she became a very competent fistula surgeon, as I believe. I'm sure you're familiar with that story. Can you tell us a bit more about it and its impact? Yeah.
Yeah. Yeah, we have the fistula patients helping us to find the patients. I think that's where their skill is very good. And we found that very powerful also for their rehabilitation, because suddenly they have something that is giving him such a purpose and value. And it's the most powerful is their story. When they go around, they tell their story. That's what convinces people to bring their daughters to the hospital early, or not to marry them off early, or to come for a surgery. It's this we can't do. Like we can't tell people. They just think, oh, foreigners don't have any idea, or even higher educated people. But if it's their own people who share their stories, then that's very powerful.
Yeah. Can you tell us a little bit about the cost? You had that testimony of the woman who said, I come from a very poor family and my husband can't pay for it, and so on. How much, perhaps in US dollars, does an operation cost? And I realize it's difficult to generalize, but in global South contexts, and is money a limiting factor in addressing this?
Definitely. I mean, it's finding a place where it's available, but it's also having the money. Like for we charge like $350, something like this.
Yeah. And is there any in Bangladesh or perhaps in other global south countries you're aware of, is there a government subsidy or help for this particular problem, or is it really just having to be borne by individuals and communities?
No, that's all these programs. I mean, the governments, they are somehow involved, but then they get the money through UNFPA. I don't know if there is some countries who really pay themselves. But yeah, most of those places where fistula surgeries are offered, they don't pay. Patients don't pay. It's for free. Otherwise, they don't even come.
Okay.
It is outside donors and maybe some from within the countries, but it's difficult even for this to raise funds also inside. Some we are getting, but mostly it's from outside.
Yeah. And in terms of the surgeons available, I mean, obviously you're an expat, you're from Switzerland, living in Bangladesh. Do you see the answer, is it both expats and locally trained people, or should we be concentrating more on training nationals?
Yes,
What do you see?
Definitely. Yeah, like we have trained here. So 2 are quite on a good level. 1 is beyond me. So all the difficult ones, I just assist her and together we are good. Yeah, so I think that's definitely the core. Because even if there is expats who want to live here for longer, it's not easily possible anymore in most of these countries now to get visa. So if we can go in and support setting up or facilitating training, like people going to this FIGO training, or then they can do themselves. But it's also for nationals, for local people. It's a big step to commit, no? Because they have to feed their families, they have to want their own careers. So it's only few who focus totally on that.
How much of your work now with fistulas is actually training other people to do it as opposed to doing them yourself?
Yeah, more mostly. Anyway, now I'm actually I'm about to step back even more. I have had struggles with visa anyway, so I've been in that role of just supporting, like also handing over the whole management of the project, the fistula project in the communities and everything. Now one of the nationals is doing that, and surgeries they kind of keep that the really difficult one we call the madam from Dhaka, and then the middle level ones that it's me and one British colleague who might also be here. We're coming and supporting, but mostly assisting because they are doing it. Yeah, but it's lots of work around it also to how to recruit them and then follow up surgeries. Maybe if I focus too much on that, it's definitely challenging, but there is a lot more around how to manage these patients. They come, they run away again, or then they have to stay for 2-3 weeks afterwards, how to help them and manage all the challenges. So it's quite work intensive all around it as well. So it's not just about surgeries. Maybe that's good to mention.
Can you talk to us a little bit more about the social isolation? You know, of course, you know, a woman with an obstetric fistula, she's probably lost her baby, so she's mourning the loss of a full-term baby. She's left with this terrible disability with urine and maybe feces leaking as well. She's been rejected by her husband and family and so on. And those distressing testimonies of people who've been effectively thrown out, can, you know, apart from surgery, can anything else be done to help communities and families be more supportive of women afflicted with this, particularly those who cannot be cured?
Yeah, that's definitely a big challenge. When they are cured, even then, like we try to help them to get back into the society. Obviously, that's different. Also, if somebody has a surgical fistula for a few months, then usually it's really just the repair. But as you say, those who have been suffering for long as outcasts. I mean, while they are here, we have chaplains who talk. We have counselors, social workers who come. So that's surely an aspect. Most powerful, I find that training that we give for the community fistula advocates. It's just 1 week, but they stay, a group of 10 people stay together And there's so much crying and sharing. I think a lot of healing also happens for them, even though it's declared as a training. But and they come from spread out from various parts of northern Bangladesh. So we have this project also to help with ITA, income generating activities, to visit them at their house and then talk also to the families and how they can support them. Sometimes it works, sometimes it's difficult. What I find most sad is when families don't allow them to come even to be repaired. Yeah.
And I guess there's, a lot of ignorance tied up with it as well. But yes, I mean, yes, I'm sure there are incredible support to one another. I was particularly struck by the stats you shared regarding Bangladesh and Nigeria about the number of cases that there are and the number of operations that have been carried out per year, and the huge gap that there is, even as you say, 5 years after the Millennium Development Goal of eradicating it. If you could wave a magic wand, what would you say would be the most important interventions to change that situation?
If I could, I would stop all the wars. That would help a lot.
Stop the
wars and conflict.
Yeah.
That's where I think, like in Bangladesh, we have a relatively stable political situation, economical situation, and often we, as fistula surgeons in Bangladesh, that's mostly nationals except for me. There is this challenge that we feel it is possible. It should be possible to end fistula in Bangladesh, but then there is the challenge of the surgical fistula. But I've been at conferences sitting beside people from Congo, from Afghanistan, and then they talk in front about this ending fistula in 5 years, 10 years. And they just know, as long as these conflicts don't end, then there is no way these women don't get any more fistula. There is no way that everybody can get treated. And that I always get very sad. We can do all the math about how many surgeons it takes, but if the whole country is so unstable, then we know the women, the children are those who suffer the most.
Okay, so you're saying in effect that this is partly, at least, the result of unstable health systems which are affected by conflicts as well.
Yeah, that's what I said. It's really a symptom when you look at how a healthcare system doesn't function and how women aren't valued and given what they need because of thinkings or because it's just not working, not possible.
Yeah. And just finally, Dr. Bia, just tell us a little about how your own Christian faith has helped you. It must be very difficult work to do, to be resilient and persisting and all the rest. And you're obviously deeply committed to it. Just tell us a bit how your faith has helped you in this whole endeavor.
I think those other fistula surgeons I know, they may not all be Christians, but they have that same fear of God and just seeing this as a calling to serve some of the least and to serve Him by serving them, being there, loving, even they have to tolerate this. Always, we tolerate some smell when we examine. That's nothing compared, but even for them, that means a lot. If we come near, if we touch them, if we have patients in the wards and they are wet again, it's so hard. But then, am I there to just stick to them and kind of try to give them still hope? It really feels as a failure when we can't cure them. But there are some voices where they also said, they have experienced love, they have experienced something, even though they still go home wet. But I think you need some kind of calling from God to do that. Maybe to keep going, not to give up, and others also to encourage each other. to continue. And then, of course, it's like there is this close big sister type professor, that she comes to work here also. And sometimes she has this really difficult situation. She just feels I will just stop. But then I keep telling her, don't, because we see the other patients. And once you see them coming and you see those who can get this new life, then that's just worth it. It's all worth it. So it's definitely, it's a challenge, but it's also an extreme high satisfaction to be part of this transformation in the life of these women. So
Absolutely. Well, thank you so much for your time today, for your testimony, and most of all for the work that you're doing and the example that you're setting as well. I know maybe there's some people listening today who've been moved by this and will end up being much more involved on the front line in the battle against female genital fistula. So thank you so much, Dr. Beer. Thank you to all of you for coming on today and joining us on ICMDA webinars. And until then, may the Lord bless you, keep you, and keep going for it. Thank you.